Okay, Assalamu alaikum everybody on board and welcome on board. Actually, the topic which I want to discuss today is not specifically centering around one point. It's actually the general approach on the principle how we should be approaching if anything which is untoward occurs in operation theater. Okay. Atik bhai, what do you think that what are the different complications or what are the different critical incidents which you can face? Just if you like tell in some short words, like what are the different sort of complications, different type of complications we can see in that operation theater.
Sir, Bismillahirrahmanirrahim. Sir, Assalamu alaikum. Sir, कैसे हैं तबीयत? Sir, are you?
Yes.
How are you, sir?
I'm fine. Yes. So, like
sir,
different sort of complications we can see.
Sir, the complication which are totally around in especially in anesthesia is sir regarding machines.
Okay.
Like fire explosion, cylinder explosion,
Okay.
sir, a fire when there is a tube, like laser surgery,
Okay.
like hypoxemic mixture of gas when the cylinders are interchangeable. And sir, human error.
Yes. Now comes to just if you start from if you stress on this thing, that if we just want to divide our complications, okay, because first of all we can divide the complications into two parts, like one are anticipated and other are unanticipated. Am I right? So what do you think? Is it a good way that we now that in that way you will be able to fix the problem? Am I right? So some of the problems are anticipated, okay, and some of the problems are unanticipated. So this is first thing. So and then you can say that anticipated problems will be related to the specific type of surgery, specific type of patient, okay, specific scenario, specific place where you can face the anticipated problems, okay. And unanticipated problems can occur where you are not mentally prepared for it or you are not expecting it, okay. Here these factors will be coming, like for example, there is anaphylaxis you were not expecting and there is anaphylaxis which occurs. This is one sort of unanticipated, okay. You like you say human error. So human error, what sort of complications can occur because of human error?
Sir, first of all, if you are not anticipating the surgery, then
human errors. I'm talking. It will be related to communication, wrong drug, things like that. Okay.
It will be if you're not labeling the drugs, proper labeling the drugs, then you can give a wrong drug. And sir, if you are you can, if the patient needs secure intubation and you put the LMA, if you are not regarding, I will first of all talk about sir, inexperience approach. Without
yes, like if you just touch the wrong drug, so it will not be only wrong drug, wrong concentration, wrong site, wrong route, okay, wrong sided surgery, wrong sided anesthesia block, anything, understand? So wrong patient, wrong blood, okay. So these will be the things which will be because of some sort of human error, like wrong drug. I again repeat, wrong drug, wrong concentration, wrong labeling, wrong site, wrong route, wrong patient, wrong-sided surgery, wrong-sided block, anything can occur. Okay. So this is because yes.
And sir, if you unnecessarily delay the surgery and you are losing the patient as well, if you're not anticipating that it is very important, and it first golden hour, if you are the trauma, especially trauma patient, and you're not diagnosing the proper, if you're not anticipating the pneumothorax, I would say, then the critical incident, then you can lose the patient, sir. And if you are
okay.
yes,
So now if for prevention of this human error or never events in anesthesia, there is one thing which is called as WHO surgical safety checklist. So anyone knows about it? WHO surgical safety checklist. Asim bhai, do you know about it?
No, sir, I don't know.
Sorry?
No, I don't know the surgical.
No, you know it. You know it very well. Just a second. Asim bhai, you know about it. Yes. You do daily this sign out, sign in, check in, time out, sign out. This is WHO surgical safety checklist. Team briefing, team debriefing.
Yeah, initially team briefing to discuss the surgical patients with anesthetists and nursing staff and with the surgeon. And then when the patient is in the room, there is
before the room check-in.
Yeah.
In the holding area. The handing over from the nursing staff to the nursing over staff.
Yes.
So what are the main points which they check at each step?
Identification of patient, name, and the MR number of the patient.
Yes.
And surgical procedure.
Yes.
Any dentures with the patient, it is removable or not. And surgical site specification, the
surgical site marking. Okay.
Yes.
Any lab, anything critical about the patient.
IV,
anything specific.
IV cannula.
Yes.
IV, which is it is functional, not functional. Anything else? Maybe here Foley's catheter or nasogastric. So they will check this patient.
All and specific allergy, like what are the more history of allergy, and another important thing which we always ask patient taking any anticoagulants, last blood sugar, last blood pressure. Okay. And any special advice, any special medication which was supposed to be given in the pre-medication. So these are the things which they check. Okay. If the blood products are needed, whether they are arranged or not. So these are the things which you are
consent for the surgical and for the anesthesia.
Consent, anesthesia consent. Okay. Rule in
swab counts or name of procedure.
No. This is we are talking. Atik bhai, we are still in the holding area. We have not made the patient inside. This is sign-in going on. This is check-in going on.
Marking.
Yes, marking. Then we will take inside the patient, and then before starting the anesthesia, the nurse will be asking, reconfirming the patient, reconfirming the diagnosis, reconfirming the procedure name. Surgeon, anesthetist will be there. They will and all. Like anesthesia equipment is there, required anesthesia equipment, and any specific concerns related to anesthetist, any specific anticipated difficult airway. Okay, so this is
estimated blood loss.
Estimated blood loss. Okay.
Specific instrument from the surgical side.
Yes. So then this is the second step. This is sometimes these two steps are done together, or sometimes they are separate. One is check-in, then sign in, And then after the patient is anesthetized and now the surgeon is giving the incision, at that time they reconfirm it, okay, and then this call as timeout, okay. So timeout starts just before incision, and some of the things are being repeated, and then they start the procedure. And when everything is finished, surgery is finished, they are closing, surgical count is okay, everything is reconfirmed. So now the nurses ask about the what was the procedure, any specific need in the post-operative period, okay, like for example post-operatively from anesthesia side or from surgical side. Now the plan was changed. Before the patient was as DSU, now patient is not fit and something happened, and now patient needs admission or going to ICU or whatever. So this will be being asked, and then they say, so it is sign out. So this is how at that time they confirm the count.
In sign out, there is special, sir, especially the if we are doing oncology procedure, the handling of the specimen, labeling of the specimen,
Yes.
and taking
Yes.
the specimen to the proper place, sir.
Yes, you are right. Okay. So these are the basic, they will not ask you in that much detail, but this is the basic concept: check in, sign in, time out, sign out. These are the 4 steps. And the purpose of this procedure is to avoid any never event, any wrong-sided surgery or wrong patient for wrong procedure, for wrong anesthesia. So this is the thing. Okay. So now another thing which is I will add to it is how there are certain care which are needed for IV lines, for central line, for arterial line, okay, for any Foley's catheter, for any like chest drain, okay, because these will be coming with the patient. So you should be very clear about the like for example, usually the central line is colored blue, the arterial line is colored red, okay. So it should be properly labeled, and special precaution should be taken care of. Foley's, we have to check where during transfer Foley's is stretched and it is damaging the urethra. So it is also part of care of your side. NG tube, okay, or any other thing which is related to because when a patient is handed over to you, it's all your responsibility. Okay. Another thing, care of fistula. Like if there is any fistula on a specific side or anything, so that will also be taken care of. Okay. Patient might have some fracture, some contracture, some functional limitation. You have to check it when you are taking over of the patient, because if you are not taking care of, you might end up having any complication. Okay. So these are the things which you have to take over. Can someone add some points to it which I have missed? Shamuna, would you like to add something?
No.
Okay. So these are the things to avoid. Atik bhai, you want to say something? Asim bhai, anyone in the house? Okay. So by these things, we can avoid, number one, wrong-sided this surgery, and care of the lines, care of a patient has allergy to something. Patient has something which is, for example, patient has latex allergy and you didn't pick it and you are using the normal equipment. So it can cause a catastrophe. Patient had some allergy to anything and now you are doing the same thing again. So the purpose of this thing is like that. Okay. So now come to the next.
The throat pack concern specialist are writing the special name on the when you are putting throat pack. Whatever you do, you should document it and make it the so that the
throat pack is one of them, very important. I forgot it. In any patient is needing any neck care, if you just try to from head to toe, if you can do like that, proper fixation of the endotracheal tube, proper, if the patient has any neck collar, you have to take care of it. Okay. And if you are making any specific position, you need special staff, you need special padding, you're like a special concerns related to positioning. Okay, so this will be also to avoid complications in post-operative period. Okay, so now who will be telling about the blood? Okay, so like blood, how to make sure we don't give a wrong blood. Yes.
For the blood,
First of all,
usually we are requesting pre-operatively for this patient, and the blood bank will provide this blood to the reception, and there are two nurses which will there will be a nurse from the
Just a
blood
second.
bank and from the
Just a second. Asim bhai, there is one small step in it. How to transfer the blood from the blood bank to the OR?
Yeah, it will have a specialized bag which will maintain the temperature of that
Ice packs.
blood
Ice
product.
packs. Yes, ice packs.
Ice pack, yeah.
And there should be some labeling over it as well, if possible. Okay, they can put a label.
Yeah, there are label on the bag, and there is paper with this bag also.
Yes. Now
And,
you are telling
from
that it is reception is checking it at first go. Then
yes, firstly they will check in the reception by two nurses, and then they will hand over to our anesthesia technician. From there, we will check together in the OR together with the anesthetist and with this technician. And after that confirming, we will sign, and we'll see 3 or 4 things in this one. One is the blood group of the patient, MR number of the patient, the medical registration number, and another thing, expiry date of the blood, and what is the volume of the blood. This we'll see, and then we can attach the blood to the patients.
okay, so then like there are some other precautions before starting the transfusion, or from our side, what will be those?
The precaution should be we checked already, but
Yes,
we'll hang the blood. And
yes, now technical things,
yeah,
like we have to attach with warmer. Number one, we cannot
Warmer,
give cold
yes.
blood. This is one thing. Number two, we have to check proper filter, 200 micrometer. Okay. Then we have to make sure the chamber is filled, because if the chamber is not filled and blood is stepping down, so theoretically there can be RB lysis. Okay. Then there can be theoretically red blood cell lysis. And regarding use of,
you will dilute with the normal saline, not with the another ringer lactate.
yes, make sure you are not attached with ringer lactate. What will happen if we are giving with ringer lactate, or the same concomitant line ringer lactate is going on? What can be the complication?
it can cause crystals. They can become crystals.
Why?
Precipitate can be.
Why?
Because I don't know the answer, but
then when you are, why are you telling? No. Here you can say we will try to find out the answer, but in exam don't do like that. Okay, don't tell. You silence will be better. If you say something and the counter question you don't know, the better don't tell. Tell the things which you are sure about. Okay, so actually there is calcium in it. So the citrate and calcium citrate will combine, and it can cause precipitates. Okay. Okay. And then I told about filters. I told about warm. Asim bhai, what will be the advantage of if diluting it?
To run faster, it will go like in the speed if you want to give, because the PRBCs are very.
Should we give blood fast?
Not fast, but if we have to give like
you are telling the right thing, but if you use some appropriate word, that will be better. That it will say the viscosity of the solution will be decreased, so the flow will be improved. So flow will improve. Okay, so this is a better answer rather than flow will be faster. Even you can give faster even without diluting. You can, if you want to flush it, you can do it. Okay, so you are telling the right thing, but if you use this word, that will be better. Okay, then what else? Anything else we can do about blood? And okay, then when we start blood, what should be the protocol?
Yes. Yeah, we have to monitor the hemodynamics, blood pressure, heart rate, and when patient is under GA, so we have to see the peak airway pressure from their side also.
Very good.
And we have to see the side from the cannula side also. There is any if there is reaction, so there will be some skin eruption or some discoloration.
Yes, so actually this will be very difficult to pick under anesthesia. Hemodynamic change, and that's why it's very tricky to give blood at any point of time. Unless there is clear-cut indication, blood transfusion should be avoided as much as possible. Okay, that's the reason for it, because if any complication occur during the anesthesia, it's sometimes very difficult. Patient is covered, light is dim. You are not able to pick. Tachycardia is non-specific, so sometimes it becomes very difficult. So that was the reason. That's the reason. So sometimes under general anesthesia, skin rash you not be able to pick. But if there is bronchospasm, you will be able to pick it. If there is hemodynamic collapse, you will be able to pick it. Okay, that's why another care. Yes, another point I was about to tell you, that the lines, especially for example, NG bag, or this one urine bag, should be in your vision. Okay, so you can monitor everything with your eyes, because if there will be hemolysis, it can be seen like that as well. So this is one of the things which you should be in the care of the lines and fistulas and joint limitations that we just discussed moments ago. Okay, so so these are actually, I'm trying to tell you in different this topic is like you can say this is a unique, that maybe you will not be asked like that, never, but the thing which I'm telling you will come in different scenarios, and if you have very good group in it, you will not miss any safety point. Okay, so so about the blood, I think these are the things which you should be taking care of, and you should have a epinephrine, steroids, resuscitation equipment. Okay, and like dexamethasone, hydrocortisone, antihistaminics, resuscitation trolley with you. You will be doing it but you can say that when you are starting the blood, you should be starting it slowly and gradually increasing the rate. Okay, so this could be something about it. So yes. Yes.
If death on the table occurs, how should we handle the death to the relatives, and how document it? Sir, have somebody having experience, so that we should do it properly, because it is a very damaged. Your morale is low, and everybody's morale is low. In that situation, you need some positive steps to be taken.
Yes, of course, this will be following. So it will be a multidisciplinary team. Like, you will not be going alone. Breaking the bad news is a special scenario which can be asked. Okay, and the basic steps here, that you have to be apologetic. You have to like you are trying to just compensate. You cannot compensate, but you have to be like polite, and you have to just give a possible explanation that this was the reason which led to this thing. There is not the administrative things are not being asked to you. I don't think so. They will ask you what administrative things are needed, but you have to properly document all the events. There, of course, there will be some CPR. So all the protocol of CPR will be followed. Okay, and then the team leader will be announcing it. So usually it will be the primary team. Usually it will not necessarily you who will be announcing the death. Okay. So this, I hope you understand. So this is another thing which this thing is true for any critical incidents, like malignant hyperthermia, local anesthesia toxicity, succinylcholine apnea. Okay, any untoward action which you are not anticipating. So same principle in it, that you have to explain what has happened, what are the possible sequelae, what are you doing, how will you manage it. Like for example, if malignant hypothermia occur local, you will be telling that it's a very rare phenomena, but it can occur in one in, so that's why you should be knowing the incidence, that how much incidence of malignant hyperthermia, how much incidence of local anesthesia toxicity, like that. Okay, so the general approach will be like that. Am I right, Atik bhai? That's what you want to ask, or anything else is in your mind?
Yes, sir, you are totally right. But what type of documentation? We should have complete documentation.
No,
And,
Atik bhai, this is not in our domain. This is not in our domain. Proper documentation means sequence of the events which occurred, which leading to that thing. That's it. Whatever you did, you have to document. You understand?
Sir, you have to document your own whatever you have done. You have to document it on.
So I have told you.
The,
so whatever has happened, you have to document it. That's it. Sequence of the events which were done, things you did for the thing which occurred. That's it. Anything else in your mind? Tell it, please.
Is there any difference in the surgical safety list with the COVID?
I'm sorry? The
Any
surgical
new
safety
guidelines?
checklist. I don't know.
Yeah, for
I
the
don't know,
COVID
but
patient, is there any new guideline?
no, we discussed about COVID patient, by the way, in detail. Okay, so usually these things are related to actually the prevention, infection prevention control. So if you go back to few days ago, we did COVID patient in detail. So you can follow it. Okay. In the channel, you can find we did a COVID patient in detail. Atik bhai, anything else in your mind, please tell, so that we move on.
No, sir, it's okay.
Okay.
You covered all this.
Like I don't understand what sort of documentation you are talking, because the things which you are asking, I have already told that we will be documenting whatever we are doing.
Sir, in the when the table on the death occurs, especially in our setup, everybody leave you. You are alone there, and you have to correct it, eat and everything. It is not Saudi Arabia that everybody has his own role. Anesthetist has to play his role like a team leader in the hospital, and have to breaking the bad news as well, and taking this right accurate steps so that
What are the accurate steps you are? Just tell me. Add on. What accurate steps you are telling? Tell me.
So accurate step means that in never step there is security, but in the civil setup there is no security. When you are making the everybody is you are alone in the OT along with your all stores. The people are coming inside. So what type of protocol, what type of security?
I think I have told you the basic principle. You have to be apologetic. You will be explaining, and that's what they will be asking you in exam. I can guarantee. I think we should move on. This is the maximum we have to tell. I don't know what you are asking, because if you are talking about security attack by the mob, this is not to be asked in the exam. Okay, you will be telling this was the happening, this was the reason, this we did, and this is the result of the sequelae. We try to do all the resuscitation, we try to give all the medications, but at the end of the day this occurred. So that's what you have to tell in the exam. Even there is nothing else they are expecting from you. The same, that you have to be apologetic, you don't have to aggressive. Yes, you are telling the right thing, that in our setup you have to be the team leader, but in the exam it's not what you are thinking. The documentation is the same thing which I'm telling you, that whatever you have done you will be documenting it. Okay, so now the other part which I just wanted to say, that what different sort of complications you can see. Like you can see some respiratory, cardiovascular, what else complication you can see in the operation theater?
Sir, arrhythmia can occur, sir. Field intubation can occur, sir. So the hypoxemia can occur, pneumothorax can occur, and the patient can go in bradycardia, the patient can go in severe tachycardia, the patient can go
Like if you
pulseless.
just divide it, classify it, I told you respiratory complication, number 1. Cardiovascular complication, number 2. What else?
Sir, airway complication.
Okay, airway complications. 3.
Sir, fourth is post-op complication recovery.
First of all, finish here. Electrolyte imbalance is a separate thing. Okay. Delayed recovery is a complication. Delayed recovery from any medication. This some of them we have already discussed, like anaphylaxis, malignant hyperthermia. This one in cardiovascular, you can explain that any swings in blood pressure, whether hypertension or hypotension, tachycardia or bradycardia, arrhythmias, myocardial infarction. So these are a list of cardiac complications. Respiratory complications, hypoxia, hypercarbia, peak high airway pressures, okay, pneumothorax, airway complications, failed intubation, okay, difficult
Severe hypertension.
Airway, failed intubation, failed mask ventilation, okay, tube dislodgement, okay, airway trauma leading to bleeding, airway obstruction, okay. So this is related to airway. Related to respiratory system, I have told you. Then cardiovascular system. What are the neurological complications?
Sir, nerve injury, positional injury because of
Immediate in the OR, which you can see.
Sir, ICB.
Signs of raised ICP. Okay, this is one thing. Number 2.
Delayed recovery.
Fits. Okay, fits, myoclonus or epileptic fits. Then, as I told you, delayed recovery, any neurological insult occurring intraoperatively. It can occur. What surgeries will have more tendency to have neurological insult?
Sir, neurosurgery, and
among neurosurgery, specifically like chair position, okay, and cardiac. What about cardiac surgery?
Posterior fossa surgery. Cardiac surgery, sir.
What is the possible reason for cardiac like neurological problems in cardiac surgery?
Because of the hypovolemia.
Because of the pump. Okay, bypass circulation, because it's a normal one. It's not the normal one. Okay, so if increase pump time, there will be more chances of renal complications. There will be more chances of neurological complications. Okay. So neurological complications will be related to cerebral ischemia, infarction, hemorrhage. Hemorrhage can occur because of severe hypertensive response. Okay, ischemia can occur if you are not able to maintain the cerebral perfusion. So it will lead to neurological problem. Okay, cardiac bypass.
Aortic surgery.
Aortic surgery, yes, aortic surgery, aortic clamping, cross clamping. Okay. So it will also
usually stroke and endotectomy.
Carotid endarterectomy. In carotid endarterectomy, there are more chances. Okay. So what about renal? We have discussed in detail. So renal complications, like what are the different renal complications which occur in perioperative period? What is the most common? What should be the first thing you should be telling?
AKI, sir.
AKI, yeah, like yes, the other word oliguria. But we are talking about the what you are facing. So oliguria. So how you approach oliguria, this is a separate thing. But oliguria is the most important thing which you can face in even ATN or AKI, whatever will be occurring. You will be facing oliguria. hematuria. Okay. What else in renal? Bladder urinary retention. Okay, because urinary retention will lead to severe sympathetic response. Patient will be really uncomfortable. Am I right? So this will be a complication which you can see related to kidneys. Anything else? Just use your brain. I'm not reading it from any book. I'm just trying to have a brain exercise. Any other thing related to kidneys which you can face?
Sir, sir, bladder rupture, ureter rupture.
Yes, any
And
injury, rupture. Yes, this is a good point. You a bladder perforation, usually bladder perforation or any damage to the urinary tract. Okay, fine. Like we just discussed that Foley's care, you did not take, so urethral injury occurred. So this is one of the complication which you can see. Anything related to joints, anything related to dislocation, fracture, and because nerve injury will occur a little delayed. Immediately, we are just trying to see step by step. So the things which you can face in the operation theater. Yes.
Loss of vision in spinal injury, sir.
Very good. Eye complications will be related to transient blindness, and what factors will be prone to it, like prone position, hypotensive anesthesia, patient having glycine toxicity, patient having baseline retinopathy. Okay, baseline retinopathy, and now it is prolonged. Spinal cord injury. Spinal cord injury can occur and will be presented as postoperative motor loss to the area below the area of insult. Okay, so this is related to in the liver or in the, there can be immediate hemolytic transfusion reaction related to ARDS or acute lung injury. So this is one of them. Some coagulopathy can occur because of blood and blood transfusion and any over transfusion, massive blood transfusion. This complication can occur. Okay, electrolyte imbalance. Yes, trolley. Yes. Overload. When we talk about cardiovascular, overload is one of them. Okay, hypovolemia and overhydration. This is, both things will come. Okay, because we are just trying to have our brain exercise, because whatever scenario comes to you, you will be facing. If your mind is tuned, that what are the possible cardiovascular complications, what are the possible respiratory complications, what are the possible renal complications, what are the possible complications related to positioning, what are the possible complications as we told about wrong drug administration and everything. So if you know like that, then it will become very easy. And from where you started, equipment failure. Okay, so equipment failure will be having any electrical failure, mechanical failure, gaseous failure, circuit disconnection. Okay, then there will be some complications related to surgical equipment like laser. They are doing laser, and there is airway laser fire. There is a laser misdirected, leading to occupational problems. So you have to be careful about that thing. Then the diathermy pad was not properly placed. There is burn. Okay, yeah, you are working in MRI and you did not take care about it, and MRI complication occurred, like you use the normal and it caused burn, or it caused problems related in the monitoring or in the provision of anesthesia. Okay, so then diathermy, pacemaker failure, you has not made it in the AICD pacemaker, you did not appropriately checked it on or make it in fixed mode, and then patient had pacemaker failure. Okay, so or a patient received a shock. Okay, because they were using the cautery and AICD picked it and shocked the patient. So this is a very serious problem. Then
postoperative burns. The postoperative burns are very common, because
yes,
when you have anesthetized the patient and
you are not able to pick them.
they are not able to. They are after 8 to 10 days they came with you with a
Like, yes,
black
no
spot.
need to tell that it will come after 9 to 10 days. It can come after 9 to 10 minutes as well. Immediately the patient, as soon as the nurse is taking over, they will find it that there is something wrong. So no need to tell specific hours. Like burns can occur in intraoperative period, explosions can occur. Okay, in the same MRI there is another something is problem related to the equipment, and from some things complication can occur because of the malfunction of MRI. So there will be release of helium, and the whole of the MRI suit staff can become hypoxic in that scenario. So there are always oxygen sensors in the MRI suit. Okay, so because if suddenly helium is released, it can cause serious problems. Okay, so any other complications? Some we discussed before. We will be actually this is a repetition of a number of things. Orthopedic problems like tourniquets, orthopedic problems like this one bone cement syndrome, pulmonary embolism, amniotic fluid embolism, in yes, fat embolism, thromboembolism in specific age group. Okay, so actually this is any other complication which comes to your mind, and then the general approach. Now I will be coming to the last part, that if you want to Asim bhai, would you like to say something? I will ask it. What is the general approach in any complication? What will you do immediately if you see any complication? Anyone from the down? Dr. Sabah, Dr. Rukhsana Begum, all are mute. Dr. Amjad, they want to say, talk something, or you are just silent listener?
Dr. Humera as well, sir.
Okay, so the general principle is call for help.
Sir, मैं सुन रही हूँ.
Yes, call for help. Approach, general approach is usually airway, breathing, circulation. This is the thing. Then you have to stop the surgeon or stop the infusion which is causing it. Okay, like we did not discuss about the regional anesthesia complications. Suddenly hypotension can occur, the local anesthesia toxicity can occur, high spinal can occur, total spinal can occur. These are the problems related to the regional anesthesia. But your approach will be like that. If you are giving epidural infusion and you are expecting some expected, so stop is one of the things. So stop is coming in case of anything. If you are giving any infusion, you will stop. If you are giving blood, you will stop. If there is any antibiotic going on, you will stop. So stop. Remember one thing, stop the surgeon, stop inhalational agent in case of malignant hyperthermia. So these are the things you should be mind, that there you have to stop something. Call for help, airway, breathing, circulation, and you have to elaborate. I will make sure patient's airway is patent. I will make 100% oxygenation. I will try to see whether there are good IV lines. If there are no IV lines, I will take the IV lines and I will start the fluid therapy. Or in case anything which is related to vasopressor or inotrope, you will start that. Okay, so this will be the approach related to airway, breathing, circulation. Then you will say resuscitation, management, and evaluation will go side by side. You will be trying to see the possible cause and what are the associated complications to it. Like for example, bradycardia alone or bradycardia with cardiovascular collapse, hypoxia alone or hypoxia with cardiovascular collapse. So this will be making the things more complicated. Okay, so your approach, whatever you want to do, then there are many things which are common thing. If the airway is not secure, you will secure it. If patient is not breathing well, or patient is desaturating, you will increase the FiO2. You will make it on hand. You will try to ventilate. You will see the compliance, and the rest of the things will be going according to the scenario. Yes.
Sir, in human error or a system error, there are two types: in human error and the system. In human error, a lack of knowledge. In human error, there is biased rules and apply wrong rules. And
I'm sorry to interrupt you. Talk about general principles at the moment, so that we are not confused. We are talking about the general principles for the managing the complications. Okay, general principles. Anything else in general principle you want to add? Like I told, call for help, airway, breathing, circulation, stop anything, resuscitation, management, and evaluation will go side by side. You will be looking at the whole scenario, okay? And you will be trying to approach the patient in causes related to anesthesia, causes related to the patient, causing related to surgery. And then you are thinking any neurological problem, any cardiovascular problem, any endocrine problem, any respiratory problem, any electrolyte imbalance. In that way you are approaching, okay? So this is the general principle.
Treat the cause, sir.
Treat the cause, and there will be some antidotes to it. For example, delayed recovery, you will be doing it with the reversal agents, you will be using it, okay? You will be giving neuromuscular reversal or opioid reversal, naloxone, or you are giving flumazenil, or you are giving duxapram, or you are, for example, if there is any electrolyte imbalance, you will be replacing. First of all, you will be assessing how much electrolyte imbalance has occurred, and then you will be anticipating it. You are calculating the possible requirement, and according to that electrolyte or according to that situation you are dealing with, like hypoglycemia or hyperglycemia or hypocalcemia or hypercalcemia, hypermagnesemia. You are anticipating the problem, you are calculating the possible loss or excess, and then you are countering it, okay? So this is the general approach. Any endocrine problem, for example, you will be replacing it with steroids, or the thing which is being, like, it can be thyroxine, it can be steroids, things like that, okay? So this will be in your mind. If there is neurological problem, actually will have to keep the patient intubated, shift to the ICU, okay? And then you will be doing later on like that. If there is, for example, myocardial infarction, then you will be involving. Yes, one more thing, where in the general principle, I forgot to tell you that in addition to everything, multidisciplinary team. In all, whenever you are explaining any complication, try to find out any multidisciplinary team you can get involved with, okay? So in every complication, there will be some team. Like, for example, if MI has occurred, you have to call the cardiologist, okay? So this is the team which you will be needing. You will be contacting with the cath lab, because maybe patient will be immediately from the surgical suite, patient may be transferred to cath lab for the further management, okay? If you are in the obstetric anesthesia suite and suddenly bleeding occurred, so the things which you will be requiring is the blood bank, hematologist, interventional radiologist, general surgeon, okay, urologist, if it is placenta previa, creta, or something like that. You will be talking to the intensivist, that because most probably patient will be going to ICU. So things like that. So this will be another part of your general answer: call for help, airway, breathing, circulation, multidisciplinary team, stop, and then resuscitation, evaluation, and management will go side by side. This answer is the base one, and you have to modify it according to the complication which has occurred, okay? Because some complications will have a little bit different approach, some complication will have different approach, but the basic thing will be that either you will be doing this approach, you will be doing some reversal or antidote, or you will be managing it in general lines. So general lines will be the same: hemodynamic support, cardiovascular support, role of any inotrope, vasopressors, fluid, giving good oxygenation, taking invasive monitoring. So this will be the general approach. Whenever you are asked any question about it, this will be your general approach, okay? So that's what I wanted to discuss today. This is not about any specific complication. This is how. And another important thing is that you have to keep your nerves. You have to be polite with the whole team members. You have to give clear commands, and you have to confirm it what they are doing, because you are not doing anything alone, okay? So you have to anticipate. Yes, gastrovascular complication, gastrointestinal complication like aspiration. So you have to anticipate accordingly, okay? So these are the things which you can face in the perioperative period in ICU usually. And ICU, there is some detailed or related to failure weaning and everything. My main purpose of this discussion was to have an approach, an insight. So because in any exam you go, they will be asking you any complication, at least one or two. Okay. So anyone wants to add anything?
Sir, I want to talk about the tracheostomy in the ICU, especially they have been asked in the previous exams, the tracheostomy complication and do 2 or 3 scenarios in different.
We will discuss Atik bhai in detail tracheostomy separately. So because you know that tomorrow I have to travel, so there will be a few days maybe break. Whenever I will find the time again, so I will come back to you people. Okay. So in the meantime, you can contact, all of you can contact me anytime via WhatsApp. So maybe there will be some break for a few days, and inshallah we will restart. Okay. So any question about the discussion we did today? Okay, thank you very much all of you for your presence. I hope you used your brain was exercised, because this is not a topic which is written in any book like that, but this is a base of a number of questions being which are being asked in the exam. Okay, everyone, thank you. Bye bye.